All right. Good morning, good afternoon, good evening, everybody. How we doing? We're going to give this second go around a try. I want to thank everybody for your participation on the first video. Really, I was surprised at the feedback I got, and the participation really was very impressive. I want to thank you for that. You know, if it's boredom or you just like listening to me talk, I'm going to kind of bet it was the boredom, but we'll go forward from there. I've got my notes on what to talk about here. Thank you for the suggestions. I received a number of suggestions on different topics. People want to hear about future topics when we get past maybe some of the core content, or even introducing some of the newer topics. Case in point is a legal video that I'd like to push out from our SERG's legal unit. I think it would be really good to hear from the FBI perspective, and I'm gonna differentiate in this video FBI versus non-FBI. What I'm going to start doing from this point on is start to include some of our non-bureau partners, some of our federal partners, DEA, ATF, other alphabets, maybe even some of our local EMS and fire departments. As a disclaimer, nothing in this video is classified. There is nothing specific to the Bureau in this video specifically. If there are videos in the future that are disseminated, that have anything that are even close to being sensitive information, which is very rare at best, those I'll keep kind of close to the chest and keep it within the FBI preview. But for the most part, this will be general information for everybody. Yes, I am violating Corona COVID policy. I'm touching my face. I was told about that in the first video. Sorry. And what are you going to do? Welcome to my house. You may hear my dogs in the background. Murphy's Law. We've been waiting for a UPS delivery for the last 2 hours. And I said, the heck with it. We're going to move forward and make the video. You know what's going to happen in the middle of this. They're going to ring the doorbell. That's all right. We'll work with that. I may show you some pictures from time to time in textbooks. I'm not endorsing any products. I'm not endorsing any publishers. That's not what I'm here to do. So if you happen to see a certain label or anything, I'm not here to endorse any product or anything at all, quite frankly. So just throw that disclaimer out there. Some of you got very creative with the code word, which I thought was funny. For those FBI personnel, at the end of every video, there's a code word. You email me with that code word, and I give you credit on NREMT. For those of you that are not Bureau, I can't update your NREMT account, so the code word really means nothing. So just ignore it at the end. But some of you are putting the code word into a sentence in your emails. Very creative. I like that. That was good. Kept me chuckling. Your NREMT accounts have been updated for those of you who did watch the last video, so go ahead and look for that. You'll see that. Let's see. I think that's about it. What I wanted to do on this video is an anatomy and physiology review. I'm passionate about anatomy and physiology. I think it's a huge piece of what we need to know in order to be good medical operators. The example I always use is, would you bring your car to a mechanic who didn't know that engine inside and out? You know, if you brought your car to a mechanic and they looked at a couple of the pieces and parts and said, I think that looks familiar. I don't know how it works with everything else, but I'll figure it out. That's not the mechanic you want to go to. Am I suggesting that we should be PhDs in anatomy and physiology? No, that's not what I'm suggesting, nor am I even close to that. But we need to have a good understanding of the human body. What I'm going to take you through today is part one of a two-part series of anatomy and physiology review. Again, as a disclaimer, I am not a doctor. I love anatomy and physiology. I'm a little bit of a nerd on it, but by no stretch of the imagination is this going to be some A&P 1 and 2 college level. No, but it's going to be, some of it's going to be advanced because I want to include some advanced material for our ALS providers. But I'm also going to keep it simple to understand. And you'll see how some of the advanced stuff will play into what we're going to look at in the future. So, structure and function. When I took A&P in college, that's what every professor would always say, structure and function. That's all anatomy and physiology is, it's structure and function. So when we look at something as far as the simplest building blocks of anatomy and physiology, from atoms coming together to make molecules coming together to make cells coming together to make tissue, tissue coming together to make specialized organs, organs coming together to make specialized organ systems coming together to make an organism, and how they all work together. I just find that fantastic in every way. I love reading about it. I loved studying it when I was in school, and I like to teach it. And any of you have taken any of my classes know that I always try to put anatomy and physiology into a program before we get started, because I think it enhances the learning and gives it a better understanding. So when we look at things as simple enough, and if I look down from time to time, I've got my books out and my notes, so I'm just making sure I'm staying on track, because I want to keep this to about 45 minutes to an hour. I can ramble on about this all day, so I want to keep myself on track here. So when we talk about the cells, I'm not going to get into a huge cellular biology discussion, nor am I qualified to do so. So we'll keep it simple. The cell in and of itself, all right? The cell wall, that bilipid layer, when we think about a cell, this isn't true in the sense of the word. To those people who are far smarter than I am on anatomy and physiology and biology and chemistry, don't throw anything at me. This is just to keep it simple. If you were to think about a cell as a balloon or a ball, right, that bilipid layer, lipids or fats don't work well with water, so it's a nice barrier. It keeps water out, but it also keeps water in. Within every cell, there are those little holes, right, or channels, that we're going to talk about later on, especially at the advanced level, where some of these channels and some of these holes or these openings within the cell are very specific. There are sodium channels, there are calcium channels, potassium channels, so on and so on and so on. So later on, when we get into more advanced topics and we talk about calcium channel blockers as drugs, or sodium channel blockers, or potassium channel blockers, we're talking about inhibiting the flow of gases, substances, whatever, through those channels. And when we get into pathophysiology a few videos from now, we're going to come back to this. There's a method to my madness. I'm not just talking to talk. Everything kind of comes into play later on. So the simplest picture that you usually see when it comes to a cell is something like this. Very basic, nothing earth-shattering. All your pieces and parts, all your organelles into a little ball, and everything has its function. Everything has its job. We're not going to go over every one of those things, trust me. The only one I really want to talk about is the mitochondria. Mitochondria, aka the powerhouse of the cell. A cell only needs three things to survive. A cell needs water, it needs sugar, and it needs oxygen. That's it. In order for us to have aerobic metabolism, that is metabolism with oxygen, in order for us to produce energy, or adenosine triphosphate, right, ATP, the cell, more specifically here, the mitochondria, needs to have sugar, water, oxygen. As long as the cell has that, the cell is happy, it produces ATP, produces energy, and we function on a day-to-day basis. If for whatever reason, whether we are hemodynamically compromised, we are in shock, and we'll get more into shock later as far as different topics, more in pathophysiology. But if for some reason our cells are not receiving oxygen, water, sugar, they can convert, and in this case, let's say oxygen, they can convert from aerobic metabolism to anaerobic metabolism, or metabolism without oxygen. In that case, we start to develop a byproduct. A normal byproduct is what's called pyruvic acid, but that pyruvic acid will very quickly, in anaerobic metabolism, switch over to lactic acid, which is bad. So as an example, we're having a heart attack. One of our coronary arteries are blocked, and we'll talk more about that in another section. But now that piece of myocardial tissue is not receiving oxygenated blood. Therefore, that tissue starts to convert to anaerobic metabolism. Lactic acid is produced, and it's this lactic acid that gives us, or more specifically the patient, this heaviness, tightness, squeezing feeling in their chest. Once you get oxygenated blood to that myocardial tissue, or if we can get oxygenated blood to that myocardial tissue, well, now we start to wash out that lactic acid, so to speak, and now the heaviness, pressure, tightness, squeezing goes away because the lactic acid production is stopped. That's pretty much it in a nutshell. So our goal, one of our goals, is to stop bleeding. Right? When we get into those March assessments, when we talk about TCCC, and even on the non-tactical side, it's all about stopping the bleeding, keeping the airway open, and getting your patient to that definitive facility. So for us, If we can keep the red blood cells in, we're maximizing our ability to transport oxygen to tissue, and we're also maximizing the ability of the body to utilize that oxygen and prevent lactic acidosis. We're going to get into a whole video on pathophysiology and shock, and we'll really get down to the weeds on that. But that's pretty much the cell in a nutshell. So let me just, and the reason I'm flipping pages here, this is kind of what I used to do when I would teach paramedic programs at the community college. Anytime I did a review, I would stand up there with a book and at the podium, and I never taught from behind a podium. Any of you that have seen me teach know this. But when I did reviews, this is how I would do it. I would take a chapter, and I would go through page by page, and I would just find certain things. And what I would do is I would ask the students directly questions. Obviously, I can't do that here. So what I'm going to do is I'm going to do sort of the same format, and I'm going to go through this book page by page and pick out little snippets that I think are important, and we'll discuss them. So once you go from cells come together to make different types of tissue. This tissue, and again, in my mind, when I was a kid, I always thought of tissue as, something solid, something firm, tissue you blow your nose with, that sort of thing. But different types of tissue within the body, epithelial tissue as an example, plays a number of different roles. We talk about epithelium, we talk about endothelium, endothelial cells. We talk about it lining vessels as an example. So capillary beds as an example, epithelium or endothelial cells. I always think of them as it's like bricks in a wall without the mortar. So at face value, it looks pretty sturdy. And you have brick upon brick upon brick, all those epithelial cells coming together. But they're only one row thick or one soldier thick if you're looking at a brick wall. But there's no mortar in between. There's gaps there. And those gaps are to allow fluid and electrolytes, gases to pass back and forth via osmosis and diffusion. And again, another topic altogether. Connective tissue, a lot of different subtopics or subcategories of connective tissue. Sub-Q tissue, adipose tissue, which is just fat, fibrous tissue, tendons, cartilage. We talk about tendons and cartilage. When I went to school and when I was working in New York, BMT was the Bronx Manhattan train, but that's how I remembered bone, muscle, tendon. So when we talk about tendons, we talk about bones, muscle attaching to bone via a tendon. That's the BMT. Stupid, but I know it worked for me. Cartilage connect bone to bone. And one of the things about cartilage and why the question always comes up, well, what's worse? If you sprain your ankle, or if you strain a muscle, or if you fracture a bone, most people will tell you that to break a bone, you're going to heal faster than to sprain an ankle. And anybody who's ever sprained an ankle, a good sprain, knows that to be true, because cartilage in and of itself is very, very avascular. There's not a lot of blood supply to cartilage. Therefore, it doesn't heal well. It takes a long time to heal. Whereas bone and muscle have a really, really good blood supply, and it's going to heal faster. So that's the mentality behind that. Bone in and of itself. I have a picture here, which I always kind of like, but I'll get into the skeletal system here in a second. But I have a picture of how bone is so vascular, and it's sort of counterintuitive, and we'll talk about that with IO placement here in a minute. One of the things that always really kind of blew my mind as a younger student was how blood is a connective tissue. I could never wrap my head around that. Well, it's blood, it's a fluid, it's liquid, it's dynamic. How could it be a tissue? But in the truest sense of the word, by definition, blood is a type of tissue, which I think is pretty cool. So let's look at the skeletal system for a second. Actually, let's look at integumentary system for a second. And it took me many, many years to learn how to pronounce that word, integumentary system. We're talking about skin, nails, and hair. And by the way, I did my hair for this episode. I hope everybody likes it. I tried to do something a little different, a little crazy, get exciting. When we talk about skin, we're going to keep it really simple. All right? 3 basic layers of the skin. Epidermis, dermis, subcutaneous. Those are the 3 main layers. The thing that I think is interesting is the stratum corneum, or stratum corneum. And do not quote me on any of the pronunciation of these words. I butcher the English language. But stratum corneum is our topmost layer of our epidermis. It is dead and there was a professor, I read a book one time, I forgot who the author was, but they basically said how ironic it is that we as living organisms are walking around and we are looking at death when we're looking at each other, because when we look at each other, we're looking at dead skin. That's all we're looking at, which is sort of weird, but kind of cool. So when we talk about burns as an example, epidermis, dermis, subcutaneous, burns always fall into those categories of what we used to call first, second, third, and fourth degree burns. Now we call them superficial, partial thickness, full thickness burns. So when we look at the diagram of a piece of skin, and 3 different layers of a piece of skin, we talk about the 3 different layers of burns. A superficial burn is just that topmost outer layer of the epidermis. It's sunburn. It's really all it is. Now, if you talk about a second degree burn or a partial thickness burn, now we're talking about a sunburn with blisters. Now we're creeping down into the dermal layer a little bit. When we start getting into third degree burns or full thickness burns, now we're working our way all the way down into the subcutaneous tissue. We'll get into burns in another lecture altogether, but the reason that they say that burns, more specifically third degree burns or full thickness burns, are painless, to a certain degree they're right. A full thickness burn, that specific piece, and I do this, there's a theory out there called the Jacksonian wound theory. You can look it up, and it talks about a bullseye type pattern on how burns work their way out from the necrotic center, essentially, all the way out to the superficial burns. But that third degree of that full thickness burn itself doesn't hurt because all the nerves are burned away. It's the outer rims and the outer, as you work your way away from that central third degree burn or full thickness burn, that's extremely painful. Only a handful of times in my career have I had patients where they were 100%, for the most part, full thickness burns. Yeah, those patients didn't feel anything, but they also didn't live very long. So it's sort of a give and take there. Let's work our way into the skeletal system now. 206 bones. Long bones, short bones, flat bones, irregular bones, all kinds of bones. For those of you who had an upbringing like mine, you were probably of the same type of upbringing where you hurt yourself and you come up to your mom, your dad, whomever, and say, I think I broke my arm. And what's the first thing they ask you? Well, can you move it? Well, yeah, I can move it. Well, it's not broken. You're fine. Horseshit. Right? That's not true. Bones have nothing to do with movement. Bones are just something for muscles to attach to. They provide structure. They provide protection, blood production, a number of different things. But it has nothing to do with movement. You can still move your arm if it's broken. It'll hurt like hell, but you can do it. So 206 bones, 6 of which are in your inner ear, 3 and 3, your incus malleus and your stapes, or your hammer, anvil, and stirrup, as they're called. These are 3 tiny, tiny little bones in your inner ear that interconnect with each other and sort of butt up against the tympanic membrane of your eardrum. So as you're listening to my nasally New York voice right now, your tympanic membrane is vibrating. It's shaking those 3 bones, which goes to your otic nerve and goes to your brain and says, hey, this is Mike Biamonte talking. Disregard what he's saying, listen to him, whatever. But that's how we hear, is based on a lot of what's based on those 3 little tiny bones. And there is some theory out there, I don't know what the theory is called or how true it is if you subscribe to it, that one of the bones in our inner ear is descendant from some sort of a jawbone of a prehistoric fish. I have no idea. You can look that one up too if you want. I couldn't tell you if that's 100% true or not. So we'll kind of work our way from the top down in the skeletal system. And one picture that I've always liked when I talk about the skull, when you look at the skull, we always think solid, one big solid piece of bone, facial bone. It's really far from it, quite frankly. And I like this picture. I'm a nerd. I got a lot of A&P books in my house. But this picture here sort of breaks down. This is just some of the number of different bones that make up the skull and facial bones. And it's pretty involved, to say the least. But I just like that picture. I figured I'd share it with you. So when we talk about your zygomatic arch, there's also a bone, this ridge up here, your supraorbital margin. This right of basically where your eyebrows are. It's just a protrusion, if you will. Some people have a greater protrusion in that area, others not so much. But our eyes are sunk back into these orbital sockets to protect them. And this margin right here is sort of pointy. So when we get popped in the eye, hit our head, whatever, and one of the reasons we get a black eye is if we get hit here, well, there's bleeding behind this area because of that bony little area. And that blood will come down and pool down in here, and we get black eyes. So that's one of the reasons. Your zygomatic arch, your maxilla, your mandible, a number of different bones. When you have time, look up Lefort's fractures. Lefort's fractures, Dr. Lefort, for all the horrible, horrible things that took place in World War II in the concentration camps, one of the things they did was medical experiments on those prisoners, which is horrific and terrible. But a lot of the science, if you want to call it science, that came out of that, one of the things, or a lot of the things they did, was to push the human body to their extremes, to their limits of how many butt strokes from a rifle does it take to crack someone's skull? How cold does a human being have to be before they freeze to death? Really, really sick crap. But one of them is looking at predictable patterns of fracture patterns in the face from blunt force trauma. And what we look at is what's called Lefort's fractures, Lefort's 1, 2, and 3. And it's a different fracturing pattern that you might see in the face, which is really pretty interesting if you look it up. One of the worst is Lefort's 3. It's also nicknamed the donkey face or the horse face, because what happens is the face actually fractures away from the skull, if you can imagine it, and the face sort of drops down, and you get this long donkey face or horse face. As you can imagine, cerebral spinal fluid will come dripping out, nose, ears, basilar skull fractures, a number of different things. So, pretty wild stuff. Let's see, what else we have? Let's look at the spinal column for a second. When we look at the spinal column, and I got a good picture here somewhere. There we go. 712554. Sounds like a bad Beverly Hills zip code or something. Right? When we look at the breakdown, cervical, thoracic, lumbar sacral, coccygeal, all right, 712554. Those are the number of vertebral bodies. So when we talk about cervical spine, we're talking about C7, C1 through 7, C for cervical. So if somebody says, oh, they have a C8 fracture, no, throw the bullshit flag. There is no such thing as C8. You're actually talking about T1, or the thoracic area, the first thoracic vertebra. So just a matter of who's talking and who's putting the sentence together. What I think is interesting is the atlas and the axis, C1 and C2. As a general rule, it's assumed, it's not always true, that if you fracture C1, C1 is also called your atlas, or your axis more specifically. So C1 is your atlas, C2 is your axis. Names really don't mean anything. If you think about Greek mythology, the god Atlas holding the world up, that's basically what C1 does. The skull, for the most part, sits on C1. C2 is what C1 sort of pivots on. And I know in sign language this means something totally different, so don't be offended if you're a sign language person. I really don't know. But if this was C2 and this is C1, it kind of sits like this, and C1 rotates on C2. This little bony protrusion right here is actually called the dens, D-E-N-S. And I don't know if they do it anymore. My in-hospital information is a bit dated, so people who still work in hospital and have greater medical knowledge than myself may tell me I'm wrong on this one. But years ago, what they used to do, if you had somebody with suspected cervical spine injury, they would shoot anterior films, lateral films, and one of the films that they used to shoot was down into your mouth. And you would lay there on a table, open your mouth, and they would shoot a picture down through your mouth. And what they were looking for was that little dens, that little bony piece of C2 coming up. And what they were looking for was, is it there? If it's not there, well, it's bad. It must have gone somewhere. What they don't want is they don't want that firing up into the brain and killing somebody. So the unwritten rule was that if you broke C1, C2, that was kind of a death sentence because your brain is right there, your brain stem is right there, and we're going to talk about the brain stem here in a little bit. So the spinal column itself, the spinal cord, passes through what's called your vertebral foramen. All right, so from the brain itself down to the brain stem, your spinal cord comes down and through, and it comes down through these little holes here in your vertebral body is called your vertebral foramen. And they end up terminating around lumbar 3, 4, somewhere in there. And that's where it kind of stops. So when we talk about somebody with spinal cord injury, that spinal cord comes all the way down to the middle of your lumbar spine, and it comes through this little area here. So when we talk about people who have broken their neck or broke their back, it's all a matter of terminology. If you were to take your chin, put it to your chest, and run your hand down the back of your spine, and the most prominent spinous process or posterior spinous process that you feel, and this is your spinous process right here, that's what you're feeling as you're running your hand down the back. C7 is the most prominent as you run your hand back. So there are people who will fracture their neck. What they're actually fracturing is either the transverse spinous process or this posterior spinous process. It hurts, and they did technically break their neck, but they're not paralyzed. The only time you're going to have paralysis or some sort of a neural deficit is if you actually have bony fragments protrude into this vertebral foramen and push onto the spinal cord. That's a big problem. And that's what we're trying to avoid when we have people who have suspected spinal cord injuries or cervical spine injuries. We don't want that bony piece going into the spinal column. There's a lot of different theories about that nowadays. Blunt force trauma versus penetrating trauma. Do we see spine? Don't we see spine? And we'll get into that later. But what we're finding is, in a lot of cases, our spinal immobilization procedure is actually doing more harm than good. So you're seeing a lot of organizations now, and I'm not endorsing one theory or one procedure or the other. You're seeing a lot of organizations getting away from spinal immobilization altogether. Maybe they'll put a C-collar on, and that's about it, and put the patient on a stretcher. In my experience, if somebody is going to have spinal cord injury from blunt force trauma or penetrating trauma, either one, it's going to already be there before you ever show up. The damage is already done. All we're trying to do is limit the extent of that damage beyond that point. So the spinal cord itself is, it's hard to describe the feel of it. For those of you who come to my programs within the FBI, you know that I always try to include a cadaver lab in my programs. I think it's just an invaluable tool to get your hands onto a real live dead body. Sounds weird to say it that way, but get a hold of that spinal cord and feel it in your hand and kind of roll it. It's firm, but it's like al dente pasta. Everything in my world is about food, booze. You know, that's kind of how I tick. It's an al dente pasta. It's about as big around as your pinky, more or less. It's not as impressive as you might think, but it's so important. But if you do lacerate that, put a bony fragment into it, there's no repairing it. That's the bad thing. We can grow new nerves, so new neural pathways in our peripheral nervous system, but we can't do anything within the central nervous system. And we'll get into those two different areas here in a minute. The chest in and of itself, let's get into the chest a little bit. 12 ribs on either side. You've got your true ribs, you've got your false ribs, and you've got your floating ribs. All right, nice. Big deal. I'm not concerned with which is a true rib and which is a false rib. It really doesn't matter in the grand scheme of things. What is sort of important for us, especially in the world of EMS, is a few different structures. All right, the breastplate itself. All right, your manubrium, the top piece, your sternal body, and your xiphoid process right here. Clavicles are also a very important piece. Look at how the clavicle comes all the way up to the top of the manubrium and way out to the top of the humeral head. So when we start talking about needle decompression, pleural decompression, and going mid-clavicular line, we have to remember that clavicle comes all the way out here, all the way into here. And we have to identify certain structures. So your sternal notch and your angle of Louis are two big structures we have to identify when we're going to do needle decompression, as an example. And we'll talk about that here in a little bit. When we do CPR and we break ribs with good chest compressions, are we probably breaking ribs? Yeah, probably. If you're doing them, even if you're doing them well and you have good hand placement, you're probably going to break ribs. Keep doing CPR, don't stop. Check your hand placement, make sure you're in the right spot, but you're probably going to break ribs. What you're initially doing is you're popping cartilage. All right? So this area here, the costal margin, right on the other side, all right, running adjacent to the sternum itself, is initially cartilage. As we get older, it firms up and really more calcifies and becomes more bony than anything else. The xiphoid process, as an example, doesn't really fully harden until we're about 40 years old, which is why when we're doing CPR on somebody a little older, we run the risk of snapping that off and actually puncturing the liver. But that costal margin, it'll snap, crackle, and pop, kind of like cracking knuckles. So initially, when you start CPR and you do that first full compression, you're going to feel that snap, crackle, and pop. It's going to shoot up your arms, and it's an ugly kind of a feeling. But that's probably what you're doing initially. As you keep going, chances are you're going to break ribs. It's unfortunate, but that's just the nature of the beast. So when we talk about that angle of Louis, all right, you find your sternal notch, and it's hard to do. It really is. It's not an easy thing to find, even on yourself. Nobody wants to see me unbutton my shirt, but all right, get your sternal notch right here, come down a little bit, and you'll feel this fusion point between your manubrium and your sternal body. That's your angle of Louis. Just adjacent to that is your second rib. You really can't palpate your first rib. It's underneath your clavicle. You can't feel it. So we use the angle of Louis as that landmark to come across and actually find the second rib. So if we look here, right, triangle of Louis, that fusion point comes right across, right to your second rib. And notice how these ribs curve up. Right? That's what they do. So when we're going for needle decompression, we're going into that second intercostal space on top of the third rib, mid-clavicular line. Right? When we're going in the anterior aspect, we'll talk about that anterior axillary in another chapter or another video altogether. But I just want to bring it to your attention as to why we use that angle of Louis as that reference point for that second rib and to go on top of the third rib within that second intercostal space, mid-clavicular line. So look where those clavicles are. Look at the starting point and the end point. So just to give yourself a better idea as to where things are. Let's see. Ooh. Pelvic fracture versus a hip fracture. Two different animals. In PHTLS, and I have the book over here somewhere, but I'm not going to look up the chart right now. If you were froggy and you felt like looking it up, go ahead and knock yourself out. In PHTLS, they give a chart of how many cc's a certain bone will bleed or hemorrhage when it's fractured. Don't quote me on these numbers. These are off the top of my head. Your humerus, if fractured, will bleed up to 250 cc's. Your tib-fib up to 500 cc's. Your femur, if it's fractured, I know will bleed up to 2 liters. Your pelvis, and this is exactly what it says. Femur, 2,000. Pelvis, massive. That's the terminology they used. How many liters of blood, how much blood do we have in our body? The average adult, anywhere from 5 to 6. So if you have one femur fracture, you have the potential to bleed out 2 liters of fluid. You're getting close to meeting the Almighty at that point. So how much blood do you have to lose? And we're transitioning into a different video now. But how much blood do you have to lose before you start to wither away and die? About half, give or take, about half. So if I've got 5 liters of blood in me, I lose 2 liters into one thigh or from one fracture. That's pushing it. How often do you see an isolated femur fracture? Not very often, unless it's from a penetrating trauma, gunshot wound, something like that. But if it's from multi-system trauma, blunt force trauma, struck by a vehicle, deceleration trauma, someone fell, you're not only going to have femur fractures, but you'll have pelvic fractures, you'll have other fractures. So that person is bleeding internally through these bones. And that's what kind of really blows our mind. And I've got some pictures here that I'm going to show you guys of bone and how vascular it really is. But I want to get back to pelvic fractures versus hip fractures for a second. There is a difference. So when we talk about a hip fracture, we're talking about a little old man, a little old lady who falls down and breaks their hip. It doesn't have to be little old man or little old lady. It could be anybody, but you know what I mean. If someone breaks their hip, what they're actually breaking is the neck of their femur, the greater trochanter. Right? Top of your femur, here, you've got that ball, right, that greater trochanter. Right here, at that neck, that is what fractures. And that is technically a hip fracture. So what you have is you have that ball and socket. So if this is my pelvis, and this is the socket of my pelvis, this area in here of my pelvis is called the acetabulum. And you end up having a lot of what are called acetabular fractures if you have that leg, that femur, come up into that acetabulum. So say deceleration trauma, axial loading, that sort of thing. You'll have acetabular fractures, and that is a type of pelvic fracture. But, so if this is the greater trochanter, this is my hairy femur, sorry, hairiest bald guy you ever saw in your life, right? I'm like a walking enigma, but that's disgusting beside that. So, femur, neck, greater trochanter, comes into the pelvis. Somebody who has a hip fracture, they fall down, break their hip, this is what they're breaking, right in here. They break this neck off. This is what gives you that classic shortening and outward rotation, usually outward rotation, of that extremity. Very painful, and for the elderly, it's almost I don't want to say the kiss of death. It's not that that's going to kill them, but statistically speaking, a few years after a significant fall or a significant fracture like that, they end up dying from a variety of other things that creep up on them, which is very sad and unfortunate. But a pelvic fracture is when you're actually fracturing the pelvis, right? This area right here, anywhere in here, that is considered bad news all around. You fracture your pelvis, you can bleed to death. And that's the tricky thing about pelvic fractures and femur fractures. Somebody can fracture, and I mean multiple fractures within the pelvis. They can bleed into that bowl, as we call it. And you, as a medical provider, won't see a drop of blood. You won't, externally, you won't see a drop of blood, but they will be bleeding internally to death, and you won't see a drop. So keep that in mind when you're dealing with big blunt force trauma, people struck by vehicles, falls, those types of things. They can be bleeding to death right in front of you, and you wouldn't even know it. We talked about that. Okay, so let's look at the bone itself, long bone specifically. This is what I always found fascinating. When we think about bones, and we have like a femur in our hand or something like that, something real prehistoric, like a weapon, we think of it as solid, menacing. You beat somebody to death with it, but it really isn't solid. Now, there is solid bone, there's spongy bone, but for the most part, when we look at a long bone, we're looking at the epiphysis and the diaphysis. Right? We're looking at the ends and the middle of a bone. But look at this area here. As we make our way through this denser bone, and into what's called spongy bone. Look at how vascular it is as we go through what are called Haversian canals and these little passageways here from the exterior. Once you penetrate through what's called the periosteum, the outside of this bone, and you start coming into the bone and getting into the spongy bone, here's where all that absorption takes place. So when we start talking about IO, intraosseous infusions or injections or therapy, it's counterintuitive. People think, well, you're drilling a needle into someone's bone. And you can do that in a number of different places for the ALS providers in the room, right? Depending on the device that you're using, you can go into the manubrium, you can go into the humeral head, you can go into the ischium or the pelvis, essentially. You can go into the femur, you can go tibial tuberosity, the malleolus, a number of different places that we can inject or drill or put that needle in. But the vasculature of that bone is fantastic just by looking at that diagram. And they're showing that the absorption rate of IO versus IV for us is negligible. It happens so fast. So me personally, I'm a big fan of the IO. So if I have somebody in cardiac arrest, significant trauma, now I may be cutting my own throat by saying this. I'm not looking to breach protocol or anything, but it's a good clinical decision-making type of a process. If I have somebody who's desperately trying to die on me, I'm not farting around with a peripheral IV. This is just me personally. I'm not telling you to violate protocol. I'm grabbing the IO. I'm drilling them. It's faster, it's easier, and it's very, very effective. So if you happen to see that in your travels, there's a lot of different techniques, a lot of different tools out there. Whatever device you decide to use, learn how to use it well, and stay within protocol. Don't listen to me. Let's see. What else we got? I'm going to make sure I got all my stuff here. Good. All right. Talked about that. We talked about that. All right. Okay. Good. I'm sorry. Give me a second here. I'll get to where I want to go. Okay. Let's talk about the nervous system. They say that the two systems in the body that have the greatest control over us are our nervous system and our endocrine system. And that makes sense. If you ever start to get overwhelmed with anatomy and physiology and you're getting lost in the terminology and you're getting really hung up on it, put it in terms you understand. Put it in things you understand. Like the musculoskeletal system as an example. Your skeleton is nothing but 2x4s of a house. Your muscular system is nothing more than hanging sheetrock on those 2x4s. Your cardiovascular system, which is next video, it's just a pump with pipes and water going through it. Your nervous system that we're going to discuss here, it's just wires. That's all it is. You get your CPU, right? Your central nervous system being your brain and your spinal cord, and you've got your peripheral nervous system, which is all your wires going to all the different areas of your house. It's really all it is. There's much more to it than that, obviously. But keep it in terms that you can understand, and things will sort of fall into place. So with that being said, let's look at the functional unit of the nervous system, just a nerve. Nerve is a wire. That's all it is. So when we look at any nerve, USA, it's just a bundle of different pathways, wires, if you will. We have myelinated nerves or wires, and we have non-myelinated wires. So this myelinated sheath, looks like a little sausage. Right? It's like these sausages right here. Right? And the nodes of Ranvier are these spaces in between that the impulse sort of jumps along on. But these myelinated sheaths are what make up our white matter, if you will, or the vast majority of our nerve endings. It's just a fatty lining is all it is. So when we talk about conditions such as MS, multiple sclerosis, it's a breakdown of that myelinated sheath. As a matter of fact, I think I have a picture of it over here. Now, is there any acute emergency treatment for MS? No, nothing we can do about it, unfortunately. But just as an example, from the picture I showed you before to this, look at the breakdown of that myelinated sheath. Now, this is just a cartoon drawing, but it gives you an idea. And then there's Stephen Hawking. He suffers from Lou Gehrig's disease. But this is that breakdown of that myelinated sheath that we were talking about. Pretty interesting, devastating to say the least. I shouldn't call it interesting, but it's an anatomy and physiology perspective. Now, looking at nerves and the nervous system, central nervous system, like we said, brain, spinal cord. Peripheral nervous system is everything else. Now, as we work our way through the different areas, let's look first at our central nervous system and look at different pathways. We could start really getting down into the weeds here, and we can talk about preganglionic synapse, postganglionic synapse, and now I'm really talking to the paramedics in the room. When we start talking about drugs and neurotransmitters and certain types of things that we might do, we start to hit certain nerve ganglia. And a nerve ganglia is nothing more than a collection of nerves in a ball all collected up together. You have sometimes what are called preganglionic synapse and a postganglionic synapse, and we're not going to get into that. But when we start talking about RSI as an example, rapid sequence intubation, rapid sequence induction for the paramedics, we paralyze patients. We give certain neuromuscular drugs that affect certain areas, and that's when we get into those topics, which we probably won't do in these videos, but just food for thought. We have afferent pathways and we have efferent pathways. All right, which is which? What's the difference? Who cares? So let's think of it this way. An afferent pathway is a sensory pathway. So whenever I talk about pathways or these types of systems, these are wires. So if I come along and I touch this screen, right, how's that? Good? No? Let's say the screen is hot. I touch it and I pull back. Say, son of a bitch, that's hot. Right? I have sensory fibers, right, afferent fibers in my tip of my finger, and this is everywhere in the body. Inside organs, I'm just using the tip of my finger as an example. Well, that sensory organ, or that sense, that sensation of being hot, goes through a series of nerves, these afferent pathways that go to my spinal cord, my spinal column, and we'll talk more about the different, it goes into what's called the dorsal root, and I'll show you a picture here in a second. It goes to the spinal cord and tells my brain, my body, hey, stupid, this is hot, pull your finger away. Well, there's another set of wires that come from your ventral root of your spinal column through what's called efferent pathways, another set of wires that goes to the muscles of your arm that pull your hand back. So there's two sets of wires in a reflex, and I'm not going to get into the weeds on this, but truth be told, that impulse never makes it to your brain. It actually only goes to your spinal cord, which is really kind of cool. But so for me to feel something, to touch something, to feel the difference between a light pressure or a stabbing pain, those are all afferent, efferent type of pathways at work, which is really pretty fantastic. So let's see if I got a good picture of it here for you. Let's see. So as an example, we talk about dorsal root ganglia, ventral root ganglia, anterior, posterior. Don't get too caught up in that, but this is just an idea of your spinal column. You have the anterior root here, which is more the front. You have the dorsal root here, which is more the back. So we already said that the anterior root here is more your motor neurons, right, telling your arm to pull back, whereas your dorsal root is more sensory. So this is a fantastically complicated topic, but think of it this way. In theory, if you have spinal cord injury, and if you disrupt only one pathway, is it possible then to feel something but not be able to move? And on the flip side, is it possible post-injury to be able to move but not feel? Yeah, it depends on what you've injured and how bad the injury is in that spinal column. Now, there's all kinds of different spinal cord injuries, Brown-Square, central cord syndrome, anterior cord syndrome. There's a lot of different neurological traumatic injuries out there. We don't get too crazy into those at the paramedic level because for us, your spinal cord is either damaged or it's not. We're not neurologists. It's not what we do. So it's pretty straightforward for us. But I never want you to be surprised if you find or you come across somebody that can feel but can't move and vice versa. Just as an example, some of the drugs that I have given in the past, neuromuscular blockade drugs, succinylcholine, rocuronium, vecuronium, these are all drugs that will paralyze a patient. But here's the scary thing about those drugs. What they do is they attack what's called a neuromuscular junction. So with the exception of cardiac muscle, which we'll get into next video, every muscle needs a nerve to plug into it to tell it what to do. All right, so for me right now, the Italian talking with my hands, I can't stop that, I'm sorry. I tried to lecture one time sitting on my hands. I stuttered like an idiot. I couldn't speak. So for me, I have to be able to use my hands. So if we have that neuromuscular junction, we have the neuron or we have the actual nerve coming into a muscle, telling a muscle what to do. this gap here, this neuromuscular gap, this space, it's called a synapse, a neuromuscular junction, synaptic cleft. There's all kinds of names for it. But there's actually space right here that neurotransmitters will carry impulses across this gap. Epinephrine, acetylcholine, serotonin, dopamine, all kinds of different neurotransmitters. So for us, if I want to paralyze somebody, and I want to paralyze all of their neuromuscular junctions, their skeletal muscles specifically, I can give them a drug. I'll just use succinylcholine as an example. What will end up happening is all I've done is I've blocked this area from any impulses going across. So your patient cannot move. It is a neuromotor blockade. It does nothing to the brain. It does nothing for their ability to feel, smell, hear, anything. They just lay there paralyzed. So think about this horrific scenario. There have been anesthesiologists out there that have been found out to be doing this, and they were prosecuted. But they were robbing patients of the sedative. So before I do this to a patient, they're in la-la land. They're gorked. I dope them up with more sedation than they can shake a stick at. So they don't know anything that's happening to them. And then I paralyze them. Some of these anesthesiologists were actually taking this drug for themselves because they had drug problems, and they were just paralyzing them. So they were laying on the OR table, completely paralyzed, not being able to breathe. You know, they had a tube in their mouth and somebody was breathing for them. But they could hear, see, smell, feel everything that was happening to them and could do nothing about it. And the anesthesiologists just kept all the screens turned away from the surgeon. They knew that this person could feel everything. How horrific is that? Laying there getting your guts cut open or your chest cut or whatever, and you can't do a thing about it. Yeah. Hopefully these people sued big. So the brain itself, as we kind of look into this now, getting away from the spinal cord, the brain itself doesn't feel pain. The brain tells your body it's in pain. So there were in one of those movies where they had the guy's skull cracked open and popped off, and they were eating his brains. Real sick shit, but pretty cool. Is it possible? Yeah, because your brain doesn't feel pain. Your brain tells you that you're in pain. And where your brain gets its information is through these afferent pathways. And what propagates that signal, for the most part, is sodium. So salt. So sodium is what keeps that signal propagating along those myelinated sheaths, those nodes of Ranvier. And it tells your brain, hey, they just cut their finger. Hey, they did this, they did that. And gives you a sense of pain. Well, we come along, if we're going to give you stitches as an example, we'll give you a drug like lidocaine as an example that is a sodium channel blocker, right? The channels on those cells. And we inject that area with lidocaine, gets into that area, and it blocks all the sodium channels in that area. So now the sensation that normally is transmitted from here to here isn't transmitted anymore because we've blocked all the neurosodium channels, and that information can't go up that afferent pathway, and you feel nothing. And that's Novocaine, or an anesthetic, which is really pretty cool. So, central nervous system, we already said, brain and spinal cord. Peripheral nervous system is everything else. Let's just go over some areas of the brain real quick, and we're coming up on our time frame here. I don't want to hold you too much longer. Big brain, little brain, brain stem. All right, your cerebrum, your cerebellum, and your brain stem. So, the brain stem, let's start there. Brain stem is pretty remarkable. That is just the brain stem itself. Pons being right in the middle. You have your medulla oblongata, you have your pons, and you also have your midbrain. Let's keep it simple. If this were to be the brain stem, all right, the three areas of the brain stem, and then your cerebrum surrounds the brain stem. This is kind of where the base of your skull is, right here, as the brain stem comes up and in. So if we have basilar skull fractures, and we have pressure in the brain squeezing out through that hole in the bottom of the skull called the foramen magnum, and it squeezes into the brain stem, we have big problems. Because your midbrain, your medulla, and your pons are responsible primarily for consciousness, sleep-wake cycle, heart rate, blood vessel diameter, blood pressure, so on and so on, all those basic life functions. So if we have pressure in that area, Because now, right, here's the base of your skull here. We have pressure squeezing down through that hole. It's squeezing this brainstem, and bad things are going to happen. You're going to go unconscious. Your breathing is going to be affected. Blood vessel diameter, everything. It's basically lights out. So big brain, your cerebrum, big movements. Of course, you talk about olfactory sense, being able to smell, see, long-term memory, short-term memory, that kind of thing, of course. But big brain, think of it this way. Big movements. Little brain, your cerebrum, or your cerebellum, I'm sorry. Little movements. So that's why I love watching infants and watching their central nervous system develop. And you'll watch it right in front of you, as a matter of fact. So if I walk up to somebody and I want to do a quick neuro assessment, say, hey buddy, do me a favor, look up here at me, show me 2 fingers on your right hand. And if they can look at me and go like this, and from a neurological point of view, I know they're intact. Because they're able to tell the difference from hearing me of what I want, follow simple commands. They know the difference between left and right. They have big gross motor movement, right, big brain, intact, of bringing up their right arm. They have fine motor movement, all right, your cerebellum, showing 2 fingers. So right there, I know everything's intact. Is it going to stay that way? I don't know. We have to constantly reassess. But a quick down and dirty neuro assessment. Hey, buddy, show me 2 fingers on your right hand. Now, if they can't speak English and they don't understand you, well, of course, you have to take that into consideration. But when we talk about infants, to watch an infant in a high chair eating Cheerios early on in their life cycle, they eat Cheerios like I used to eat chicken wings on a Friday night. No control. You're just a mess, and they have no fine motor skills. But as this baby gets older, and you watch this baby in the high chair, and you start putting Cheerios down in front of them, slowly but surely they start 2 fingers to the mouth. 2 fingers to the mouth. And you're watching big brain and little brain start to grow together. I think that's wild to see something like that. Let's see what else we have here. Real quick, we'll start wrapping this up. We talked about your peripheral nervous system, which is pretty much everything else. And as you subdivide your peripheral nervous system, we break down into sympathetic and parasympathetic nervous system. And for the advanced providers, sympathetic, more your adrenergic fibers, and parasympathetic, more your cholinergic fibers. So when we start doing anatomy and physiology, strike that. When we start doing pharmacology, we'll talk about adrenergic response, cholinergic response. And really all we're saying is it's a sympathetic type of nervous system response or a parasympathetic type of nervous system response. And the neurotransmitter for sympathetic is epinephrine. Oh, I'm sorry, let me do this. Somebody's trying to call me. Let me get rid of that. There we go. I think we got it. We still there? Yep, still there. Good. Sorry about that, gang. So we have sympathetic, parasympathetic, fight or flight, feed and breed. 2 different ways of thinking about it. We're going to get heavy into that in pharmacology. We'll get more into that when we get into pathophysiology. But that is a branch of your sympathetic nervous system. And we'll get into receptor sites, whether they be alpha, beta on the sympathetic side or muscarinic or nicotinic on the parasympathetic side. So fight or flight, feed and breed, as a general rule, and we'll get more into this later, your fight or flight, your sympathetic, speeds you up, right? Gets you pumped up. Whereas your parasympathetic slows you down. Not always true, but we're going to see the differences as we move forward later on. One last thing we'll talk about is what sort of covers everything up. When I say covers everything up, what covers your brain and your spinal cord is what's called your meninges or your meningeal lining. I think of it as PAD, Pia Arachnid Dura, and that's sort of working from inside out. So the lining that actually coats the inside of your skull. So if you do an autopsy and you pull the skull cap off, there's a tough inner lining on it. And it really is pretty tough. And in Latin, dura mater means tough mother, so it makes perfect sense. So we can pull it out. It's a very tough, fibrous type of tissue. That's your dura mater. Your arachnid space, arachnid meaning spider or this spider web-like labyrinth in between your dura and your pia mater, it's where a lot of your cerebral spinal fluid is found, is in that area there. And your pia mater, It's almost like a piece of cellophane wrap that actually comes in contact with the brain and coats the brain. So when we talk about epidural bleeds, epi being above, we're talking about a bleed above the dura mater, between the skull and the dura mater. Your epidural bleeds are typically very fast bleeds, arterial bleeds, and will hit your patient very hard and fast. Whereas a subdural bleed is typically more venous in nature, a little slower. It can be also referred to as a subarachnoid bleed or an intercerebral bleed. These are slower bleeds as a general rule. So if we have somebody who takes a blow to the side of the head, typically it's what's considered your middle meningeal artery, deep down in there. That'll be ruptured, and that'll create an epidural bleed. So how you'll see that in some patients is they'll take a blow to the head, a fall, blunt force trauma, car accident, whatever. They'll go unconscious, but then they'll wake back up, and they'll ask you those repetitive questions. Hey, what happened? What happened? What happened? And now, instead of their mental status slowly but surely getting better, their mental status slowly but surely starts getting worse. And that's an ominous sign. So later on, we'll get into the Glasgow Coma score, and when we start to see a deviation downward, that's a poor prognosis versus an uptick in your GCS. That's a good prognosis. So we'll talk about that more later. Your reticular activating system is a series of nerve endings that are all part of your brain, and it's sort of the reset button. For those of you who remember pinball, tilt, right? If you shook the pinball machine too much, the machine would tilt and your little clickers would stop working and it would piss you off and your ball would come down and you'd lose your quarter and you'd be mad. That's what your reticular activating system is. It's sort of a reset series of nerve endings. So if you get popped in the jaw, watch any MMA fight, boxing, whatever, somebody really gets hit. They'll go back, they'll lock up, they'll kind of go like this, pass out, and then they'll wake back up. What just hit me? That's the reticular activating system, sort of hitting the reboot button. So a lot of times in car accidents, you'll hear about that. Oh my God, they were unconscious. I know, right? They got their bell rung. Now, are they concussed? Do they have a bleed? These are all things that we'll talk about later when we get into head trauma. But those are the different things to think about as far as the vasculature and how it applies to your meninges and different terminology as far as your meningeal lining and where your bleeds are. There's no way for us to tell with 100% certainty pre-hospitally, but there are things that I'll talk about later on that'll sort of point us in the right direction. All right, let's see. I think I've covered most of everything. We're right at an hour now, so I don't want to hold you any longer than that. Again, you can tell I can talk about this stuff all day. I love this stuff. I'm a nerd. What can I tell you? So for those FBI personnel, please go ahead and email me on low-side with the following code word: ribs. Right? Delicious, functional. Right? They do their job. So ribs is the code word for this presentation. For my non-FBI folk, thank you for watching. I hope this helped. If you have any questions, you know how to get in touch with me. I don't really like to post I'm not going to post my information like social media. I'm not a social media guy. But those who know me know how to get in touch with me. I hope you liked the video. Please keep the emails coming. Please disseminate this to whomever you think it's going to help. We'll do AMP2 next week. Have a great weekend. Stay corona-free. Be safe, be healthy. And thank you again. We'll talk to you soon. Take care. Bye.